Assalamu alaikum. Today I'm going to read a typical legal case 29, that is, a 3-year-old boy admitted with lethargy. We have a 3-year-old boy who has been getting progressively more tired and sleepy over the past week. His parents noticed that he is drinking more water than usual, but he is eating less. Apart from this, there are no other specific symptoms, no headaches, no vision problems, no recent illnesses in the family. This tells us that whatever is causing his condition is not likely to be an infection or something affecting his brain directly. The lab results show a high sodium level, a normal potassium level, high urea, and a high creatinine. His glucose level is normal, his urine dipstick is normal, but his first morning urine osmolality is quite low. Normally, when a person is dehydrated, the kidneys conserve water by making concentrated urine with a high osmolality. However, in this child, the urine is dilute, which is not a normal response to dehydration. The most likely explanation for these findings is nephrogenic diabetes insipidus. This condition causes the kidneys to be unable to concentrate urine, leading to excessive loss of water. As a result, sodium levels in the blood rise because there is not enough water in the body to balance the sodium concentration. The child's symptoms of lethargy, sunken eyes, and dehydration supports this diagnosis. Nephrogenic diabetes insipidus is a rare condition in which the kidneys are unable to concentrate urine properly. This happens because the kidney do not respond to antidiuretic hormone, also known as vasopressin, which is responsible for controlling water balance in the body. As a result, people with nephrogenic diabetes insipidus produce large amount of dilute urine and become dehydrated if they do not drink enough fluids to compensate for the water loss. Let's understand normal water balance and ADH function. As in this image, in a healthy person, the body's water balance is tightly controlled. The kidneys filter blood and produce urine, but they also have the ability to reabsorb water back into the bloodstream to prevent dehydration. This process is controlled by antidiuretic hormone, which is released by the pituitary gland when the body needs to retain water. When a person is dehydrated or has a high sodium level, the brain detects this imbalance and signals the pituitary gland to release ADH. ADH then acts on the kidneys, specifically on the collecting ducts and distal tubules, to make them reabsorb more water. This leads to production of small amounts of concentrated urine to conserve water. However, in nephrogenic diabetes insipidus, the kidneys do not respond to ADH, no matter how much is released as a result. Even if the body is dehydrated, the kidneys continue to produce large amounts of dilute urine, leading to excessive water loss. This causes the sodium concentration in the blood to rise because there is no enough water to balance the sodium. This condition is known as hypernatremia. Causes of nephrogenic diabetes insipidus can be congenital or acquired. Congenital nephrogenic diabetes insipidus is a rare inherited condition that is usually present from birth. It is caused by genetic mutations that affects the kidney's ability to respond to ADH. It can be X-linked, autosomal recessive, or autosomal dominant. It is caused by mutations in the AVPRS gene, which affects vasopressin receptor 2 in the kidneys. Since it is X-linked, it is more common in males, but females can be mild carriers. Autosomal recessive or dominant nephrogenic diabetes insipidus, it is also rare and caused by mutation in the AQP2 gene, which affects aquaporin 2 channels in the kidney tubules. These channels normally help transport water back into the blood, but in nephrogenic diabetes insipidus, they do not function properly. Babies with congenital nephrogenic diabetes insipidus drink excessive amount of water, have frequent urination, and are at risk of dehydration and high sodium levels. Second type is acquired nephrogenic diabetes insipidus. It can also be caused by damage to the kidneys due to various medical conditions or medications or imbalance in the body, like in chronic kidney disease, in electrolyte imbalances, or in lithium toxicity. In chronic kidney disease, due to a lot of damage of kidney, reduces the ability to respond to ADH. In electrolyte imbalance, high calcium levels or low potassium levels can interfere with kidney function. And in lithium toxicity, long-term use of lithium can damage the kidney and cause nephrogenic diabetes insipidus. In urinary tract obstruction, conditions like hydronephrosis, swelling of kidneys due to blocked urine flow can affect kidney functions. And because of use of certain medications, some antibiotics, chemotherapy, drugs, and antivirals can damage the kidneys and lead to nephrogenic diabetes insipidus. Acquired nephrogenic diabetes usually develop gradually and may improve if the underlying cause is treated. The main symptoms of nephrogenic diabetes insipidus are related to excessive urination and dehydration. These are polyuria, polydipsia, dehydration, hypernatremia, and poor weight gain in infants. If nephrogenic diabetes insipidus is not managed, severe dehydration and electrolyte imbalance can be life-threatening, especially in young children. Doctors diagnose nephrogenic diabetes insipidus using a combination of blood tests, urine tests, water deprivation tests, and genetic testing. In blood tests, they can check sodium, potassium, urea, creatinine, and glucose levels. There is high sodium in nephrogenic diabetes insipidus. Potassium is usually normal or strictly low, and blood glucose is normal. Urine test is to measure osmolality, and they see urine is very dilute despite dehydration. This means the kidneys are not consuming water properly. In water deprivation test, the patient is not allowed to drink water for several hours, and doctors monitor urine concentration. In nephrogenic diabetes insipidus, urine remain dilute even after dehydration. To differentiate from central diabetes insipidus, synthetic ADH is given. If urine concentrate, it is central diabetes insipidus. If urine remains dilute, it is nephrogenic diabetic insipidus because the kidneys are resistant to ADH. Genetic testing confirmed congenital nephrogenic diabetic insipidus caused by mutation in AVPR2 or AQP2 genes. There is no complete cure for congenital nephrogenic diabetic insipidus, but symptoms can be managed with proper treatment. Increasing water intake, patient must drink plenty of fluids to prevent dehydration. Infants may need frequent breastfeeding or formula feed with added water. Dietary changes. A low sodium diet reduces the amount of sodium in the blood, which can help control thirst and urination. Medications to reduce urine output like thiazide, amiloride, and indomethacin. Thiazide diuretics reduce urine volume by increasing sodium and water reabsorption in the kidneys. Amiloride, often used with thiazide to prevent potassium loss, and indomethacin help reduce urine output by increasing kidney sensitivity to ADH. For acquired nephrogenic diabetes insipidus, if caused by medications like lithium, stopping the drug may help. With proper management, most people with nephrogenic diabetes insipidus can lead to normal lives as long as they maintain adequate fluid intake and follow medical advice. Infants and young children require close monitoring because they cannot express thirst properly, which puts them at higher risk for severe dehydration and complication. In case of acquired nephrogenic diabetic insipidus, treating the underlying cause may improve symptoms or even reverse the condition. Early diagnosis and good hydration are key to preventing complications. Here is the first question. What is the most likely cause of his electrolyte abnormalities? Select one answer only. Let's rule out one by one. First option is primary hyperaldosteronism. It causes high sodium levels, but it also leads to low potassium levels. Since the child's potassium is normal, this is unlikely. Next option is rotavirus causing vomiting. It can cause dehydration, but in that case, the kidney would try to conserve water, making urine more concentrated. This child's urine is very dilute, which does not fit here. Next option is salt poisoning. Salt poisoning would also cause high sodium levels, but in that case, the body would try to get rid of extra sodium by making concentrated urine with high osmolality. Since this child's urine is dilute, salt poisoning is unlikely. Next option is syndrome of inappropriate antidiuretic hormone. It would cause low sodium levels because the body retains too much water. This child has the opposite, too much sodium, so this is not the answer. So the most likely diagnosis is nephrogenic diabetes insipidus. As we already know, this is a condition where the kidney do not respond to antidiuretic hormone, which normally helps the body retain water. As a result, the kidneys cannot concentrate urine, leading to excessive water loss, dehydration, and high sodium levels in the blood. This explains why the child is drinking more water, because his body is trying to compensate but still has worsening dehydration. His low urine osmolality confirms that his kidneys are not properly concentrating urine. Second question is, what is the most appropriate fluid regime to provide at this time? Select one answer only. First option is IV fluids at maintaining rate with 0.18% saline, 5% dextrose. It would still contain some sodium, which could worsen the hypernatremia. So it's wrong. Next option is IV fluid at maintenance rate plus 10% with 0.9% saline. It would provide even more sodium, making the problem worse. Next option is oral fluids at maintenance rate plus 10% with 0.45% saline with 5% dextrose. It still contains some sodium, which is unnecessary since the child mainly needs free water. So for treatment, the best answer is oral fluids at maintenance rate plus 10% without saline. This means giving the child extra water to replace the fluid he lost. It is important to correct sodium levels slowly because rapid changes can cause dangerous brain swelling. If the child is able to drink, it is best to let him take fluids by mouth because the body can naturally regulate how much water it needs. This is all about from this case. If you have any question, comment below, like, subscribe and share.